So this is case series, table 1, and you confirm the before. And table 2 is about data from the UNOS. And here is the cause of death. But I just UNOS told me that the actually malignancy, primary and metastatic, they can't distinguish because it was put by each researcher, so they can't distinguish. So I will make a footnote over here. And this is table 3 from the international registry. We don't know about the recurrence as well, like UNOS data, but we could find the death and cancer specific death as well. And
that type type of DLT sequence.
yes, there was one case of non-sequential, but in about the cancer specific death, it could not be analyzed because the non-sequencer patient died with other reason. So I had to exclude it. Then the only sequencer group is remained.
Mhm.
So that's why I couldn't make it. Do I need to make a footnote again?
I mean, I guess this is just one patient, so
Yes.
it's hard to make any.
Yes, this is
No.
not reliable actually. Yeah, I described it in manuscript. There was a significance, but it's not reliable.
Wait. There's a significance,
Mhm.
but if you look at the 95% interval, it's overlapping 1.
Mhm. Oh. Oh, I will check again. Sorry.
Yeah.
Mhm.
Okay.
And about the CPB, there was no case using CPB. So this column is kind of weird.
Yeah. Why don't you just describe it in the text?
Okay. I will
Saying
remove
what
it.
you,
Yep.
yeah.
Got it. Okay. And this is table 4. I don't know this table is really neat or not, but I just wanted to tell about the cause of death, which came from UNOS and international data.
Would there ever be overlap of patients?
I'm not sure. Maybe or maybe not, because maybe surgeon does not put the data in both registry. Maybe use just one.
I think we have to make that clear. That
Mhm.
maybe ask both organizations that
Okay.
they might not know, but
Mhm.
do you know of any case that could overlap with this registry, or is there a potential? And they might say, well, we know some are overlapping, but they may say something, just ask both of them.
Oh, right. Okay.
And then whatever you get, just write that in your method.
Okay.
So the reviewers know there could be potential.
Mhm.
And that's the valid reason not to merge.
Mhm. Mhm.
Because some might say, why didn't you merge data? And then you can say, number 1, there could be potential overlap. Number 2, these data, well, they have a policy of not merging, just in the method so that people know, because reviewers will ask, It's hard.
And Liam, do you think table 4 means a merge of data? Because UNOS have a policy that should not be merged.
To me, it looks okay because
Mhm.
we haven't merged the data to do a combined analysis. We did put it in the table together, but I mean, we're just comparing. This is just descriptive, so
I think after completion this manuscript, I need to send them and get some feedback.
Yeah, let's do
Yeah,
that. I think
okay.
it's okay. Okay.
Alright.
Oh,
Uh-huh.
other than. So. Let's see. Oh, it's okay. You can, yeah, it's okay.
So table 1, and I want to show you the figure. So this is a figure 1. I made this more clear. And this is figure 2 about the state case series. And you confirmed it before. And this is the state. I just figured out how to make together cancer specific survivor and overall survivor. It looks better, I think. And this is international registry. And also you can see the value and overall survivor and cancer specific survivor. And this could be a supplementary figure 1. It is about the post-transplant malignancy, whether it could be lung cancer or not. All kinds of malignancy. Any comment?
So, post-transplant malignancy, if you get them, I guess long-term survival goes down. So we don't know when they got the malignancy, right? We don't have that timeline.
We have,
We have the date of.
yes, we have.
So maybe then you can come up with time to malignancy.
Okay, got it. Good idea.
Yeah.
Okay.
That would be just one curve because you're not comparing it to anything else.
Yes, could it be fine? Do you want to make it A and B or
Yeah.
supplementary figure 2, A or B?
Yeah, figure 1A, 1B.
Okay, okay. I'll make it. So, let's go back.
And in the text,
Mhm.
our argument is that, we don't know whether, well, in non-lung cancer indication transplant, malignancy is still major cause of death, likely related to lifelong immune suppression, and survival is impacted, as you see in this graph, in the time to diagnosis of malignancy, is represented in this graph or something.
Mhm.
Okay.
Okay. And this is the message from the UNOS I showed you yesterday. Okay, now I'm almost completed the surgical section. So I'm studying, and Sam also finished the translation research. So I will combine that. soon. And this is the next project, ctDNA in HER2-positive breast cancer. So our IRB is approved completely, and the samples are now shipping. So maybe within this week, Predison will get this. Actually, Predison asked one of the hard copy of manifest, but my Korean team, I guess they missed it. But I think that is just a hard copy, because I sent them manifest already.
Okay, that should be fine.
Okay.
So 123 samples
Mhm.
from how many patients?
34 patients.
Oh. So only 27 tissue?
Available. Yeah.
Okay.
Mhm.
Okay.
Okay. And this is court 2. Now Korean team is finding the samples because it was so old samples, and there were 3 candidates of proteomics, but Intervan and Bertis, they were not interested in this study, so only Biodesk is remained, and we're still waiting there.
What was the reason that Bertis wasn't interested? Liam, do you remember?
Bertis wanted to focus on lung study.
Just lung?
And then a smaller kind of caveat to that was Amy, who is the medical director, I believe. She's
Yeah.
on maternity leave, and since she left, it seems like the conversations regarding the breast cohorts halted. So Sang-tae Kim did say that if he hears anything back from Amy regarding the project, they can pick it back up. But Sang-tae's understanding of the situation is that they'd like to just focus on the lung cohort for now. And where the breast cancer cohort stood with Bertis prior to that was they're crunching some numbers to see if the sample size would be sufficient, for the power and things like that for their analyses. And we haven't heard anything back regarding that. So it's a bit of a up in the air kind of situation, I think.
Okay.
So I'm sure if we wanted to like chase it down a little bit further, we could, because it didn't sound like it was a hard no. It might have been, but they just might not have explicitly said it like that, but definitely something we could follow up on.
Because if they only need, let's say, 150 microliter, we still have blood, right?
Yes.
So let's not totally cross out. Maybe I will.
Mhm.
And where are they with lung cohort? Liam.
Lung cohort, they're completely on board. We've signed the MTA. We've confirmed their lab manuals as well. So Bertis is pretty much good to go. The only other thing is we're waiting for the cohort A stuff, which I can talk to you more about when I'm presenting. But we were able to confirm the number of samples. We've sent that information along to Hugh for budgeting and invoicing. But Hugh's on vacation through this week, so he returns next week.
So just the budget stage, Bertis?
Yeah. And that's just for cohort A. Cohort B and C, they're done with everything.
Oh, okay.
Yeah, so they're going to now ship us the tubes and test materials that they would like to use.
Okay, good, good. Just follow up with you next week and maybe shoot Bertie's email one more time about the breast. Because yeah.
Sure.
Okay, biodesics, where are we?
Internal discussions on their end. We haven't heard back yet.
Okay. Maybe follow up with them. It's been more than a week. So just follow up. CC.
Okay.
Lunit. So question is, should we send them on stain slides too or no?
Actually, they didn't confirm.
So because the last time Dr. O said they don't have plans to do additional staining themselves. They need to get funding. But is it better for Gyeongbok to have it, or Lunit can store it there, and then if reviewers want to do additional staining, then they can stain it. Find another vendor to do it.
No problem.
Yeah, so I think sending it all to Lunit, and if let's say reviewers say we really want to know what that cell is, the B cell, T cell, macrophage, what is it? And then they have unstained slides, so they can just stain those cells and compare. You know what I mean?
Oh, yeah.
So for that purpose, I think Lunit can keep it. We don't have to return to Gyeongbok pathology team,
We don't
right?
need to.
So yeah, let's plan to just send everything. And if Lunit asks why you're sending on slide, then or if your reviewer asks anything, we want you to keep it for future purpose.
Okay.
Let's do that.
All right. So that means the aim of the study should be only focused on details first, right?
First. Yeah, right now the Lunit they can assess TLS and tumor budding like manually because they have pathologists.
But I say pathologists are so busy.
You know, you can say TILs, and in the secondary exploratory analysis, you can say TIL is the main, but you know, other pathologic features such as TLS or tumor burden, including but not limited to, so that we can look at anything else later.
Okay.
So yeah, primary and secondary, you can, yeah. Okay.
This is all I have today. And I need to make a presentation about tumor budding. Do you want to do right
Yeah,
now?
let's do it.
or-
Let's do it.
Okay.
Let me ask, Eugene, are you able to stay?
Oh,
Because we're gonna do journal club first, or do you wanna go first?
If I can go first, that would be great. Because I have only 2 things to ask you, so
Okay, let's do that then.
yeah, it won't take long.
Okay,
Yeah, thank you for considering.
if while you prepare, I'm gonna take 1 minute break, okay? Okay, let's go.
Yes, probably you can see the screen which is shared, right? So yeah, I'm gonna give you updates on 2 projects today. So for the transfusion survival like manuscript, I think Liam already looked up the manuscript, and manuscript wide it's ready for submit. But I'm still working on table with Uni, and this is kind of a made by Uni, the format, and then I actually modified a bit. I just wanna ask you to confirm this format and then the the contents if you can, so that we can finalize all the fill in the blanks. I mean this is the table 1, and it's the length is only within 2 pages. I think it will be not be a problem. So as you commented, we changed the order of columns and try to be more succinct in terms of rather than just describing the result. But I need to keep the 2 columns of confounding factors and sequence relationship. I'm not sure whether I really need to specify each variables that are considered for each paper, but I do believe this is something the readers might be interested in considering the results. Also, actually up until the red colored ones are done by me. I'm planning to ask Dr. Yoonhee to help me to double check everything and nice form with the thing. So you can just look at the long section give us any input. So for example, one of my specific question would be, would you prefer just say no association, or do you want to still keep the actual value?
Yes, actual value.
True value as well? Okay.
Yeah.
Okay, then I see. And then for the subgroup, it's a little bit tricky, but you want the separate result. Do you want to keep the separate results for subgroup? It will make the table more lengthy, of course, but for example, this paper, I haven't finished it yet, but they just report the results are only significant for the sub, not in general. So I think that's why Uni keeps results like this. I'm wondering like whether there should be some mentioning about this is the result about the subgroup, or is it just good to like this?
So so that
Yeah, they
That
when they
paper
specify.
just used subgroup? They didn't,
No, they use the whole group, but then the whole population wasn't. But so, so for the general group, there should be no association.
so I think you have to report both then.
Both, okay. Then I'll try to make a 2-row.
Yeah, two
Yeah.
row. And you have to all groups and you can do,
Right.
you know,
The total and then subgroup.
yeah.
Hmm. And then for so we only have we make the 2 main columns for the results, like OS and PFS. Some papers they only
PFS is,
progression-free survival.
so these are all, is this all, what stage of cancer are they?
Oh, but I think for the most paper stages are there. They obviously they control stage for most of the paper.
So in your
Yes.
mind, what is the proportion of stage 4 versus non-stage 4?
I guess definitely stage 4 would be small because papers deal with the transfusion that happened while or during the operation. So my guess is probably most of the patients should be in an early stage, to get surgery. So I don't believe there will be many like stage 4 patients. At the maximum stage 3.
So PFS is
seriously,
usually
yeah.
used in stage 4. Recurrence-free
Oh.
survival is, I think, maybe more appropriate.
Mm. Oh, I'm a little bit confused. So do you mean that can I actually change PFS into recurrence-free survival, or should I have to treat them separately, slightly differently? Yeah, some paper did report kind of recurrence, like here, but not many paper report like RFS. But can we treat PFS as an RFS?
No,
Oh no.
RFS is well, I think it's important to say, if there is an exception, then you say it's exception, but most cases you say are non-metastatic case where surgery happened or local therapy happened
Yes.
with curative intent.
Oh,
I think it's important to say that so that people know what group are we talking about. But I do think there may be one like stage 4 paper too. So I don't know. You have to specify.
okay. My guess is there won't be many, but I'll check whether there is or not. Because most papers are dealing with the transfusion which was done perioperatively. So I think personally it would be great if we can see the transfusion done regulated for chemotherapy or something. Unfortunately, there are not that many papers. Okay, I will try to differentiate them. But do you feel comfortable with just like I just kept sample size and then try to separate the number of people who received transfusion or not, like this, and transfusion details and OS, PFS, or RFS. factors that are considered and whether there were those response relationships or not.
Yeah, it's okay. It's okay.
Okay. And you're okay with me detailing every single compounding factors like this, right? I even think that whether should I just say propensity score for this time and then make a supplementary table, with all the detail about the considered factors. Um,
So let me ask you this. So when you see hazard ratio here, were they adjusted hazard ratio?
Yes,
Or
I try to keep adjusted hazard ratio. And if that's the case, I kept which kind of variables are adjusted for this hazard ratio. So
but if there's no adjusted, if it left blank, then they didn't do it.
I am thinking to try that. Yeah.
So
But up until now, yeah.
you have to explain that in the footnotes or
Okay.
so hazard ratio,
Oh.
presented here, you can put asterisks or something. Here
mm,
is adjusted hazard ratio, controlling for these factors. If the confounding factors were left blank, that means there was no adjustment.
mm,
So you just have to exactly say what you did so that people know.
Okay.
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 And same thing in the method and the result. You have to say this is adjusted hazard ratio or this is what it is, and when you explain it.
Yeah.
Adjusted,
I
what,
will do that.
yeah.
Mhm. And for the table 2, which is dealing with the meta-analysis result, this is the format. It's a little bit different from the previous one. Study number and sample size, and other than they're pretty much similar, but because meta-analysis, unfortunately, one of their limitation is it was hard and to control like all the compounding factors for each individual study that are included. So not many paper mention about compounding factors, so I kind of delete that. And also response relationship as well. So I just try to denote some particularly interesting facts in this column, like because
Okay.
some paper, yeah, okay. Let's see here. Okay, so we will
Wait. Explain to me what those are.
the particular things. I think for this paper, they did great job on figuring out the whole whether there's a volume equation. So it did that, but I'm trying to make it more like
What
detail
is
as I
OSCSS?
CSS is case sorry, I delete actually this is not the original file, so I deleted that. CSS was cancer specific survival. I'll but
Yeah,
there's
I think that's right. Yeah, cancer specific.
yeah, and CSM is cancer specific more.
So you have to write that all out in the footnotes, right?
Right. Actually there was, but yeah. It was missed while copying.
So what does that mean, volume association? Like I don't.
Yeah,
Volume,
I should, yeah, I agree. I
is
should make it more
volume
clear.
big volume?
Probably with high chance. But I did that for the individual study like this. I try to denote each volume point where they find some difference, the unit difference. And maybe I'll do that if
Volume and unit same?
that's my guess. I think when they calculate the fused volume, they use the unit. So like how many units were transfused at one time, something like that.
So you I guess those responses, it's obvious, but I still want you to describe directionality. You know, higher unit transfused associated worse survival or something. You just write volume and death. You know, we don't know what you're trying to say.
Okay, so
So you can write hazard ratio that says it's worse. And if you write hazard ratio,
my only just concern is that maybe that would make the table more choose or Berkey. If I have to if I have to keep each hazard ratio for each different, like with PFS, I'm sure what I can do that.
if it's listed, I have to say it.
Would it be possible if I can make a supplementary table for that, or just in this? I'd like to show you some example of paper which report
Okay.
this. Just give me a left. View, okay. Oh, like here. Like this. See the difference of each different units and then their ratio.
Okay.
So as of now, I only kept this number. The last one.
Oh, units, overall survival.
Overall survival and disease-free survival and also recurrence, but I omitted recurrence.
Hmm. So survival is worse, disease-free survival is
Worse.
worse. Recurrence is not.
Yes.
So why is recurrence? Well, I guess is this what stage are these patients?
I think it was a lung cancer patients who are in their mostly. Oh, if you see the like matching rates procedure. This is ratio that I've used. Then the pathology stages are pretty spread from stage 1 to 3.
Okay. Okay, very interesting.
I think I can collect some paper who relationship in these detail. Maybe I can make another supplementary table. And just mentioning that they looked at relationship in the table 1 as like this.
I still think in table 1, you have to show header ratio. You can't, because you're not, it's not
Mm.
being fair to other columns.
Okay.
Other columns you have it, so you still need to put, I know it's going to be longer, but I think it's better than going to supplemental.
So
And
in that way,
you can put, you can choose overall, just be consistent. OS,
oh, here this is not provision period. Yes, they use quite a variety of terms across the paper, so it's hard to kind of unify to find the most appropriate.
yeah,
Or
1 or 2
yeah.
measures. Yeah, it's okay.
Okay. I'll just try to list them.
Biologically, it's important to show more transfusion leads to more cancer progression, because if you need more transfusion, you're sick. So you can die of anything else other than cancer. That is called, in epidemiology, that's called confounding by indication. If the indication itself is, means that you're sick, you're gonna die sooner. So people can die sooner, not because you have cancer recurring, but because you're just sick, you just required more transfusion, right?
Right.
So that doesn't say anything about our topic. Our topic, we have to be able to say, if we transfuse more blood, we get more cancer. We have cancer progressing.
Yeah,
So
definitely.
that's more important than, yeah.
Then I'll just delete this column and try to keep each result below each study.
Yeah, that's
Including, yeah. Okay. Sounds good. Yeah, other than that, I think we're good for this project. So as soon as we finish up the can submit, and then luckily there are so many people who are helping me right now, so I don't think it will take much of the people's. And the second thing I just want to speak to you briefly is that for the case report on early differentiated thyroid carcinoma, I tried a bit more to fit the format of European Thyroid Journal, and I was short on time to ask the co-writers to read about it. So I'll just let you know when they finish up their comments, and then if we are ready to submit, then I'll just briefly update you, and then I'll submit it. But then I have a question. I want to ask you about the figure actually.
Mhm.
So yeah, and then yeah, as you recommended, I went to see Bioporter, and then I was able to get some more information about the mutation, what that happened to the patient. And thank you for your input. And for so we have two figures for this paper. I'm okay with the figure 1. Shows greatly how the treatment was effective for the patient. Like then for for figure 2, which is this, not sure whether we have to keep it or not, because for this paper the main point is to show the efficacy of the temsirolimus and nivolumab to thyroid carcinoma. But then if you look at this figure, it looks like I think it's a little bit confusing, because to me it looks like the efficacy are there even before starting temsirolimus, and I don't think this really highlights the efficacy of temsirolimus. Like the plasma only ctDNA actually started to decrease even before starting Temsi, and then thyroglobulin as well, and tumor informed the ctDNA as well. And even for the tumor burden by RECIST, it did show some kind of progression while patients are on Lenvima and Nivo-Ipi, but then to me it looks like the cabozantinib. Yeah, so I wish that we could draw a little bit or whether there's some resources to see like whether there's a slope change, or like patient did well on Temsi for how long. I guess she was doing well on Temsi at least more than 5 months. That's what I paper, but this graph actually didn't show that. So
So there
like-
there were no more markers after the 9th month?
this figure was made when we were there around April, like May. So
Oh,
I think Irony did great job on making this figure, but I think for this figure to be meaningful time point, I think we definitely need to update it, or just to like not to use it.
yeah. So looking at the figure, it looks like a Cabo
Yeah,
really
Kevo
worked.
did great job, but then what we mentioned about Kevo was discontinued because of the side effect.
Yeah, she couldn't tolerate it.
Yeah, but we didn't actually talk much about the Cabo in this paper, so
I know.
yeah,
Oh.
Kevin and they was only this. And also like it says like due to disease progression and toxicity, but here in the figure 2, it looks like it is desynchronized with what things.
Yeah, it's not disease progression, it's toxicity alone.
Okay. Oh,
I don't know who wrote that disease progression.
I thought this manuscript itself had already been read together a few times, but maybe there was some mistake. So yes, then I'd like to reach out to anyone who is available in the lab to gather.
So Arnie is coming next week. Let Arnie
Perfect timing.
update figure 1. Jian,
Actually, this is the figure.
please work with Arnie when she comes.
Okay, no problem.
Okay, then yeah, definitely this figure has to highlight Timothy. I think, yeah. Okay.
And you
That's
have to
all.
say in the discussion,
Mhm.
I think we do have to say from figure 1, it seems Carbo had Harbo might have initiated the molecular response.
Mhm.
But it was quickly discontinued for major toxicity concerns.
Okay.
We have to say it. You know,
In the discussion,
yeah.
I don't think I did that. Yeah. Okay. And um, maybe, maybe I can add that. Okay. Yeah. So it was been rejected in JCOPR, and then their main like comments was they don't think it deals with the mechanism of what happened enough. So I try to elaborate more on the mechanism. Yeah, and hopefully it can be accepted in the European Thyroid Journal. So it would be okay if I submit it after Arnie come back to the lab, and then after she finishes the figure 2, right? In the meantime, I'll just keep updating the manuscript itself.
So where are we submitting to?
European Thyroid Journal, we decided it a few weeks ago.
European Thyroid Journal.
So this is something that they require. Okay, so yeah, I only have 2 things for today.
Oh, that's it?
Yes.
Where are other projects?
So other projects that I didn't mention today are like sensor incidents. The manuscript is, so I reached out to Suwon and then Eileen, who volunteered for the writing manuscript. Actually they're in their final exam period, so I gave them a few more weeks to work on the things, and so there's no major update for that. And then other than that, oh, MRD, yeah, so Natera will, I think you probably also, you're in the loop of the email right now, and then they told us, like, last update they give us is they will get back to us by the end of this week after finishing all the data analysis and finishing up the swimmer plot. So yeah, still waiting for that. And other than that, hyperprogression, yeah, we're still working on that as well, manuscript. And that's gonna be Arnie's main project when she come back to the lab, I think.
Hyperprogression paper?
Where
is it written or where is it? Is it, who's writing it?
Yeah, I can show you briefly. So we finish it deciding the title, and then abstract I try to write it, and then for introduction Arnie has been working on this portion, and then for the materials and methods, I think Dr. Jion and I highlight the part that I wrote as a blue. And
So
for
Eugene, you have a lot of projects that you're involved and you're
Mhm.
still the manager. So just like what Liam is doing, why don't you make a PowerPoint as he presents?
Mm.
You know, name of the title, who's the project lead, who are the authors, and who's doing what piece and where things are when what's the deadline for each person. Let's write it all down and you present it every time you're in the because it kind of helps to see where things are. I think that's what we need.
Okay.
So what's the bottleneck? Who has to do what to move this forward?
Basically, like we divided some part to write. So introduction for Arnie, and I'm trying to do as much as I can, starting from materials and codes, and I'm trying to write the results section kind of into 3 parts, like incidents and between like, PFS and OS, and then like decision between HPD and clinical pathology levels. We didn't find any significant. And then discussion. I think Arnie wrote a little bit all things that needs to be written in this part. And yeah, maybe we can divide it among her when she come back. And I'm willing to be also writing discussion part as much as I can after I finish the results part. I'm still working on the results.
Okay. So I think going over the project is important because the way I can help you guys is prioritize things. So transfusion is a really important topic. However, hyperprogression is timely topic. You don't understand because if someone else presents, what we find, but transfusion, there's not much competition. You know what I mean?
I know. Yeah.
Same thing, ctDNA space, MRD space, ctDNA, tissue DNA concordance, high competition. Okay,
Right, right.
so
Definitely, I
we
have to
can't
focus
sit
on
on the data. Same thing, early cancer detection. We can't sit on the data. Data is coming out so fast. So that's how we prioritize things, not based on undergrads, final exam time. If they can't do it, you do it. Okay, it's just based on who's available and what is the deadline. That's how we move. It's not based on, oh, this seems easier, I can do this. No, everything gets prioritized based on what is timely. So I can help you do it. If you don't present, I have no idea what's going on and who's doing what.
You're
So
correct.
the
Yeah.
presentation is about, yes, I'm involved in project number 1, 2, 3, 4, 5. And as a PI, I will tell you, you focus on submitting this first. I'll leave it up to you to get some help. And that's autonomy that I give you. Some PIs don't give you that. You just finish, do your own thing. That's your work. Okay. But I have open policy. You can, if any lab member want to help you, feel free to get help. But on the condition that you don't wait for them, you give them deadline, they don't finish. You are the responsible person to finish. You can't blame that person, okay? It's ultimately falls on your, responsibility. So I would argue that MRD, hyperprogression, and if the person is like, oh, I can't do it because I have other exams and other life issues, then we move on. We give the project to somebody else so that it doesn't sit and wait. Okay. So I mean, a lot of it falls on me how I manage it, but I think it's going to help a lot if I think Dr. Jian and Liam is doing it. If you write it out, what's the priority, and I think you just have to prioritize. There are so many things.
Yeah, right.
Finish this and then move forward with the next. But also, if you're project lead, you are a middle manager. How do you work with others? And the lesson is you can't wait for others. You give them deadline, and if they don't do it, You know, it's like a contract. You don't get credit if you don't do it, you move forward. Okay,
Then you just give us a rough deadline for HPD and MRD project. I think.
yeah, so I think both are priority. And then my concern is if we don't finish it by the end of the year,
Mm.
because today is the last lab meeting of the year. Next Tuesday, I'm in Mexico, Next.
I see.
and then 20th, 27th, I'm not in the lab.
Mm.
I will be
Working.
working from home or driving or doing something for my family.
I see.
Um,
Understood.
so it's not like every week I will tell you to do this and that. You only have a set time that you can get my input.
Mhm.
So again, if you have burning question, you can still, even my vacation time, you guys are welcome to shoot me messenger text asking me any questions. I will answer within 24 hours. But as far as the projects are concerned, I want you to prioritize and set deadline and be consistent.
Um, try to finish up the whole manuscript and figures by maybe within 2 or 3 weeks, hopefully, and then update you about the manuscript
Yeah.
within this year, and then maybe earlier next year we can.
And then when you present in a publishable quality, finish everything you can, and then get my input. If you have a question about major direction of how you write things, then you can ask it in advance.
Okay. But then
But as
other than
far
that,
as the formatting, grammar, everything, I want you to be perfect.
understood.
Mm. Okay, any other questions?
Yeah, not anymore. No.
So hyper progression, where are we, what journal did we decide to submit?
We haven't decided yet, actually.
So did we decide on the title?
Yeah, we decided on the title.
Can you pull it up?
Oh. I'm sure. This is the title that we settled on maybe 2 weeks ago. I think.
Redefining hyperprogression in clinic, the incident and risk factors of hyperprogression in non-small cell lung cancer treated with immunotherapy. Okay.
But is it okay to omit prognostic value or because with
Prognostic.
prognosis of what kind of prognostic impact that hyperprogression did have on our actual patients? So like the correlation between OS and PFS, it doesn't look like it the self implies that.
I don't
Incidence of,
understand what you're saying. Can you repeat?
oh, okay, so I mean, while writing main results, I divided them into 3 parts, like incidence and risk factors, like association between person and then and OFS and PFS. So it feels like we kind of missed one part of that of them.
Incidents. Clinical implications. incidence, comma, clinical implication. And risk factors. Is that? What do you think, Jian? Does that make sense? I didn't want to say clinical outcome or survival because hyperprogression itself is
Sort of.
sort of, you know. Okay, let's leave it at that.
Yeah, and actually it would be helpful if we can decide which journal we're targeting, because the format
How many patients is this again?
patient itself is 121
129
129. Okay.
or
actually.
21.
Still pretty decent size. Let's aim for MCT, Molecular Cancer Therapeutics, AACR journal.
MC.
Very good journal.
Understood.
Is there any benefit when the abstract is accepted in AACR?
Benefit?
To be published.
What were you thinking? Or what?
Because you told me this journal is belong to AACR.
Hmm.
Well, as you know, most of the journal which is belong to any conference, then they give some guarantee, not fully guaranteed, but part of guarantee when the abstract is accepted or presented.
Oh, if I think there's some, maybe it's some advantage if you presented it at the AACR before. And then we previously published in many AACR journals. My paper got the, here, best of the AACR journal. And then if you go AACR, you get, if your paper gets the most cited paper, you get to be invited to like reception, award ceremony, and it's nice.
Okay. We didn't submit this abstract to AACL.
Oh, okay. It's okay. Paper.
I just asked.
Yeah. But it's okay. I think we can submit. And
Okay.
last time I couldn't go to the award reception, so I let Dr. Iser Kim go. So she went there, she ate there, and she brought me the cup and the award trophy.
Oh.
And you get most cited journal booklet with your picture and paper abstract and all that. So it's an honor and people celebrate together.
Sure.
It's better than, to have a, ACR journal is a really nice achievement. Yeah.
Try to do my best.
Let's,
do our best.
if we don't get there, then the next. How about JAMA Open Network? Do you think they will be interested? JAMA Open
Honestly,
Network.
not knowing much about them, not knowing much about them. So
JAMA
Oh.
Network or something. Yeah, it's like, this is where double lung transplant was, Anki Bharat's paper was published here, right? Was it? Yeah.
oh
Yes.
yeah.
Okay, let's have that as a second option.
Okay.
So
So
MCT is hard.
this will be our top priority project, and then followed by MRD.
Yeah, both are top priority because, people are publishing a lot, fast. And if you don't publish it, you're just gonna have to update, and reviewers are going to say, why didn't you cite this? And you know,
For MRD, I think we didn't kind of set the target journal for this.
we did not. Okay.
Discussion should be enhanced.
Is it short? Is it, it's a short report?
No, it will be like not too lengthy, but it will be like the amount of just like as original journal or
Can you show me the whole paper?
yeah, abstract. I'm not sure why there's no entry. The methods like the patient characteristics and the factor treatment and then discussion. Not there. We're still working. But I'm trying to refer a lot of the paper that by Abush on this similar topic. There will be table figure will be increased. This shimmer plot will be added here. And then tables are
Okay, for this one, let's shoot for clinical lung cancer. If they don't take it, the second journal can be lung cancer, which is called lung cancer. If they don't take it, one translational. There's a translational lung cancer.
cancer research.
Yeah, TLCR.
As a third target.
Yeah, let's do it that way. 1, 2, 3.
Yeah, I think I figured out what I need to figure out. So yeah, mostly. And there is no more project that I like have on my list. So yeah. I'll unshare my screen and anyone can yeah, we can move on to
Okay. So it's December.
I know.
So
Really need yeah, it's a really real time to rest on
I think for MRD hyperprogression. So here's the thing I wanna emphasize. We thought about everything. We have all the data we need. We did the abstract. I think as a lab, what we are not, doing well is from abstract to actual publication. I think we just stop putting our efforts in actually publishing. And I think I just acknowledge that's our weakness. So I will try to focus more on get it done before we I mean, it's important to submit abstract. I want all of this for your success. And also to present our work, but if we stop there and not publish in a timely manner, my mentor Kurdrak used to say, it is a sin not to publish, not to share with the world what you found. It is a committing sin. Same thing, if you do a trial and if you don't collect tissue or blood, it's a sin. You get this concept? You know why it's sin? It's a very important opportunity to learn if it's working, why is it working? If it's not working, why is it not working? If you do the trial and you have no clue why it's working, patients have given you precious time, and you're just wasting everything. Okay. If a drug is working and you don't publish in time, people don't know it's working. And other parts of the world, they don't know how to apply that knowledge.
Right.
So again, we're not doing research to pad our CV. Okay, we're not doing research to get promotion to be intern, resident, fellows, professors, associate, full professor. These are not the reasons we're doing research. It could be a benefit, additional benefit. And then time will tell whether research is important to your life or not. But at this stage, I want you to take it dead seriously that we have to report what we found. Okay.
Okay.
Okay, let's take 10-minute break. I have to return some calls and then we'll get back to Dr. Jian. Eugene, you can listen to her journal club because I think it will help you. Okay.
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 Yeah. Thank you all for giving me like a reading.
And how are you, Eugene?
I actually did finish another interview.
Whoa. How many
early
interview you completed?
4 as of now.
4. How many remain?
4 left.
4 left.
Yeah.
Awesome. You're gonna get anything.
My lips started to crack up again. I think. Thank you so much. And yeah, but I feel actually, Dr. Jian, like I'm not sure whether it feels so hard for me to write a manuscript, way harder than just write a abstract. Maybe because I read not enough. But it's a little bit of
Well, actually, in my opinion, the manuscript can't be perfect because there is other opinions when you read the same article. So if you think it's enough, I think you can just submit. Then the reviewers give your several comments. Sometimes with the reviewers comment, I totally rewrite the article and I get a new one. But there's still potential to be accepted because the reviewers give comments. That means I got major revision. That means I have a third chance to get some chance to be published this article. So you don't need to make it perfect. That can't be perfect. Whatever you think this is
Agree.
perfect, but someone when read this one, oh, this is weird. Why didn't you do this? Why didn't you do this? But still, we follow the Dr. Chat's opinion, but the article never can be perfect, I think.
I agree. I do
So,
agree that. Yeah.
yes, actually, I can't understand why the most of lab members stop to submit, even the manuscript is completed. This is the most exciting process, exciting part, submission and waiting the result. Well, because I usually use the American journals. They give me the answer mostly during the nighttime.
Yeah.
So
Because of the time
yes, when I have really exciting, when I wait a really exciting result, sometimes I check the email.
in the midnight, like
Yeah, in the midnight, I just wake up and check the when I get the accepted, then I yeah. My husband,
That's
what's
like a
going
full
on?
moment.
Yeah,
yeah,
yes,
like,
this is the most exciting part. One of my article, actually, I got 40 times of rejection because
40.
of only one part. I just revised and revised and revised, but whenever I submit this article to the other journals, they give us just some comments and then reject it. I really wanted to give up, but this is my baby. I can't give up. So it just spent 2 years, and then this article could be rewritten with a longer follow of oncologic outcomes. That was the point. Every reviewer said it. This is too short. The follow period is too short. But during the 2 years, I got longer outcome.
Yeah.
And then it is published in the SCI, the Australian
Wow.
journal. Yes,
It made it in the
it
end.
yes, it happens. So don't give up. Yeah.
Yeah, maybe the fear of expected, and then
Mhm.
I think I kind of say everything to avoid that.
Mhm.
So yeah, I'll just give it a try and then as much as I can, and then try to submit it anywhere. Yeah.
Even if you get rejection, don't be upset because other journals will accept it. It is just
That's not the
depending
only
on
one
the
journal.
scope of the journal. So you can
Mhm.
find the appropriate journal.
Thank you so much for your advice. Yeah.
Yeah, don't give up.
And yeah, thank you
Those
so
are my babies. You
much.
should remember. You can't give up your
Yeah.
baby.
Maybe because you're already mom, so maybe you'll know more than
Yeah, I have more than 100 babies. Yeah,
Wow.
that's
I
still
see.
interesting, really interesting. You
So-
know what? In these days, I'm writing a lung transplantation article.
Right.
It's not easy because I don't know the surgical technique and I don't
Right.
know the process. So I'm starting now. Do you know the
Oh,
difference?
you look very excited about it.
Yeah,
That's the key point, I think.
yeah. Do you know the difference between cardiopulmonary bypass and ECMO? I thought they were same, but it wasn't. Totally different.
Totally. I
Cardiopul
think the core mechanism is similar, right? But then the more the duration is
but
you
you
can.
can it can't be same because
Ah.
cardiopulmonary bypass means really cardiac, lung, they were connected, not through the body, but through the other way. But
Okay.
ECMO is usually using after surgery. That
In the
means
ICU.
the heart is not opened, it's a closed state. And then we can use the other device, ECMO. So
Okay.
ECMO is one of the cardiopulmonary bypass, but basically real cardiopulmonary bypass is heart to lung. So CPB is only used during the surgery we can use. Yeah,
Yeah,
that was
I saw
that
that.
was the
Yeah.
point. Yeah.
I see. So
I
Is it
found it
okay? Yeah,
yesterday.
wow. Really? Thank you for sharing what you learned. Just what you just learned.
Yeah. Yeah.
So to the ECMO, you mean that we need to connect artery and
Vein, yes.
vein?
Mhm.
Oh,
Usually we use a femoral vein, and mostly we use it in ICU, not during the
see.
surgery.
Mm.
But because ECMO is modified, now the surgeons can use the ECMO during the surgery with the advanced technology.
Mm.
So it could be safe right
Interesting.
now. Yeah, but
Yeah.
at the basic, they are totally different. Yeah.
Yeah, the operation itself is really different.
Mhm.
Like which are connected to each something.
Yes. Yeah.
Mm.
I was very shocked that there are many studies comparing
Mm.
both
Mhm.
because I thought they are same. Why they compare?
Ah. What did they compare? Like,
Um,
Like-
because in CPD they use a high dose of heparin anticoagulant,
yeah.
but ECMO they use a low dose
Mm.
anticoagulant.
Mhm.
So the side effects are different,
Side effect.
like bleeding or
Mm.
leu- leukopenia.
HIT. Oh yeah.
Yes,
Some,
yes.
yeah.
And
Oh,
graft
okay.
failure
Heart
and
failure as well.
yes, mhm,
Mm.
and pulmonary function, yeah, cardiac,
Okay. Okay.
cardiac
But then for
for you.
for our case, how is it implied to your like studies? Do you like
I'm
separate them?
writing just a review article.
Review article. Okay. Review.
So I read it.
So you need to be
and analyze. Yes,
describing.
yes.
I
yes.
see.
Yeah.
Wow.
Anyway, interesting.
Thank you so much.
But
You look
still,
like
I
you look
don't
like
know
a like
about the
French
lung
student.
surgery at all.
But I
One
Yeah.
of the breast surgeon from Asan last week,
Mhm.
he visited our hospital and he
Oh.
asked me, why you working in lung clinic?
What did you answer?
uh, pulmo breast surgeon.
What a creative.
Yeah.
Yeah. Yeah. Wow. Interesting. And you've been there almost for like half a year, I think. Not half, but
Just
1/3, I
months.
think.
4 months.
4 months. 4 months. So
Mhm.
Mhm. How is everything for you?
Well, my life is so stable.
Stable?
So I'm really happy because I can focus on my research. When my life was not stable, I couldn't
Mm.
focus on my research and writing articles.
How did you write up to 100 while you were doing surgery?
Well, usually I write an article on the weekend.
Weekend.
Mhm.
Very focusing on, yeah.
Because I like.
You
If
liked
I
it.
don't like, I just had to, then I would not do that.
Mm.
But because it's
See.
interesting. Mhm.
Interesting.
Yes, interesting. Mm.
I was so surprised by being like the soccer players who just finished
Mhm.
their like World Cup games. They would feel pressured for their games, like especially for when they have to beat like the Brazil, like the such a huge like counterpart. But then
Mhm.
literally like players, Son Heung-min or Lee Gang-in, they look on even for the toughest challenging like
Mhm.
counterparts. So that really made me think about myself as well.
Mhm.
How I feel when I deal with like sometimes seemingly tough research topics or questions and papers. So I hope I could be dealing with that like them, like or like you, like with more light heart. But that's not the case for me, at least for now. So hopefully we'll see what happens. If yeah, I'm still
Yes,
figuring out whether this is something for me.
always a struggle. And
Mhm.
the actually a revision
Mhm.
is the most difficult part. Sometimes the reviewer says totally different way wrote. But if I don't accept this comment, then I need to give up.
The chance to be
So
published there.
yes, yes,
Yeah.
yeah,
I see, I see.
there is conflict, blah blah blah.
Mm,
But most times I accept. They are better than me. Yeah,
I see.
I think.
Yeah.
Yeah.
Yeah. Thank you for sharing this experience. I think I did publish, I haven't experienced publishing like paper, but most of the time, as the main author, like I had my mentor who did the toughest part on behalf of me. So maybe be- I think I'm for these projects that I'm dealing with right now. I think myself as a like more like a responsible. Maybe I feel more pressured on
Mhm.
dealing with the difficulties. But I guess I go through this time very well, then I may feel more fun about doing these things. So that's kind of what I'm looking forward to. But still, I think I have so many steps to make make papers that I'm still
Mhm.
writing to be published. So pretty daunting job for me, honestly. But we'll
Yeah.
see.
Just submitting
Just let me. Okay, just try to sum.
to make more revision. Yeah. You know, the in one article there are many authors and they say one or two comments. And sometimes
Mm,
I just I'm exhausted with their comments because
mhm.
yes, two different professors says totally different thing. This guy want to fix this.
Okay,
Oh,
I'm
hi.
back.
Okay,
We had a small talk.
yes, on research.
All right, Jian, you ready?
Yes, I'm ready.
And then
Yeah.
Journal Club by Dr. Uni as well. Uni, are you ready to after this?
Yeah, I'll do my best.
Okay, I'm gonna start first. So this topic is not actual journal, but journals. I want to make a present about tumor budding and solid cancer. So, tumor budding is not familiar to me as well. The tumor budding is a histologic phenomenon which is separated from the cancer, and only the pathologist can distinguish these small cells. Yeah, even it looks very similar with the main cancer. So we can use the several staining technique. Anyway, the tumor budding cells are individual cells, which is consisted of less than 4 cells. When the more than 5 cells, we call it differently. So anyway, this is the concept of tumor budding.
What is it called? More than 5.
Oh, we'll see. I will I will tell you later. Yeah. Okay, so the history of the tumor budding was started late 1940s. It's been more than 60 years. But at that time, it was not interested. The researchers said it is related to stomach cancer, tongue cancer, and larynx cancer. But in 1980s, there was a strong relationship between tumor budding and colorectal cancer, and many researchers started to have interest in this part. The mechanism of tumor budding is when the cancer lose e-cadherin or downregulation of EpCAM, then the cell-to-cell adhesion is lost. Then the cancer cells are coming from the main tumor, and these separated cells can go into the bloodstream. That may lead poor outcome, poor prognostic outcome. So tumor budding was a strong relationship with the colorectal cancer. Actually I can't fully understand it, but what I could understand was when the cancer shows a decreased e-cadherin expression and the downregulation of EpCAM, then there could be a potential the presence of a tumor budding.
Mm,
But the problem is there is no standard classification.
mm,
Many pathologists, they give their own definition, own criteria, and there are so many different criteria, but that means we can make something if we are the pathologist. Anyway, some researchers use only presence or absence. Sometimes they use the number of buds. Each tumor bud are consisted of less than 4 cells, but we can count the tumor bud, 1 tumor bud or 2 tumor buds. And then sometimes the researchers they use the intratumoral stroma tumor budding or extrastroma tumor budding. So anyway, the point is there is no standard classification until now. But the definition is mostly accepted less than 4 cells means the tumor bud. And you can see the various outcomes, the various classifications from 1990 up to now, 2017. And they use various classifications. Sometimes they use the
go back?
scores. Pardon?
I'll go, prior slide, prior. One slide before.
Okay.
Yeah, so it started 1993, the first paper. Is that what it,
No, it was started in 1949. I told you the history of tumor bud.
49?
Yes, 49. Tumor bud, the first concept was tumor bud. It started in 1949. But
People-
then late 90s, the colorectal researchers, they had interesting and
So
they found it.
Colorectal field.
Yeah, yeah. Most are colorectal.
Well,
These are all colorectal.
all colorectal.
Yes.
And a lot of Japanese researchers have,
Yes, because this concept in late 90s, this concept was started in Japan. There were many pioneers in Japan.
in
There
Japan.
are only one United States under
Wow.
1999.
Wow. That Japan is very strong in biology. Yeah.
They are strong in pathology actually.
Biology? Oh.
Yes, they see very thoroughly.
Oh.
Yeah, you're gonna be shocked. I've been 4 or 5 times to Japan to see the hospital,
Hmm.
and always I'm surprised
Mm,
if they're working.
I see. Okay. Okay.
Mhm. You want to see?
Oh no, next.
No, okay.
It's a proposed
Um,
system. Okay.
yes, but sometimes they use the scoring system, negative, mildly positive, strongly positive. And sometimes they use just a low grade and high grade.
Mhm.
The conclusion is that when the presence of a tumor burden is related to poor prognostic outcome.
Yeah.
Mhm. So 2016, there was one recommendation. There is a consensus for reporting tumor burden, only tumor burden consensus. It's interesting. Yes. And especially in colorectal cancer, they focused. And one of the articles shows recommendation to make a standard how to find the tumor burden. And they says only H&E slide is enough,
Mhm.
no more any staining. And 10 individual fields at minimum power to identify the hotspot
Okay.
and count the tumor burden. And they divided the tumor burden as 1 to 3, low, intermediate, high. This is depending on the number of tumor burden.
So so you have to define the field first and then find the highest degree budding. And then with that 10 individual fields,
Mhm.
you pick a 10 field and then
Yes, within one slide.
within one slide, and in that field, you count tumor buds. And then you tumor bud count per that area normalization factor. That is. Okay, anyway, that area is it 0 to 4? Yeah. Okay. Straightforward.
Maybe the LUNIT, the pathologists who belong to LUNIT, they know about this process.
Okay.
But there some confusing between bud liking structures and real tumor bud.
Hmm.
There could be inflammatory infiltration, just
Mm.
like beside the invasive focus. So this is only distinguishable by pathologists who has high experiences in this field.
Mm.
So it can't.
Mm.
Mhm. And confusing factors, you can say real buzz versus the lymphocyte, the histiocyte, or real buzz versus stromal cells. And there could be some artifacts just look like a bud looking appearance, but this is not a real bud. So we need to know these factors that could be confused. When you see the colorectal, there are many studies. Anyway, most of the study shows that the presence of tumor bud is related to poor outcome. And mostly they are involved in lymph nodes,
Mm.
most end stage.
Mm. Well, what about survival?
Also the survivor is related to tumor bud because when the higher end stage means that the higher stage,
Mhm.
and it is a fact to the survival.
Okay.
And the tumor bud related lymphovascular invasion is also a key topic in recent articles. But I just wanted to say that the H&E slides are enough to the pathologist But if we are not a pathologist, but we still want to see the tumor body, then we can use the pancytokeratin. We
Mm.
can distinguish this is the main tumor and these are the tumor buds. But still, we need to count each cell, number of cells. And here you can see the tumor body and TILs, they say a little bit different results. Well, low tumor body and high TIL has best outcome.
Mm.
High tumor body and low TIL show worst outcome.
Mm.
But between these middle group, they show similar. High budding, high TIL, low budding, low TIL. I'm not sure there is a statistical significance or not, but the graph shows a similar in stage 2. And in stage 3, it's quite have a gap between two groups.
Yeah.
And this is the answer what you asked. When the cancer cells is more than 5, then we need to call it poorly differentiated cluster, not tumor bud. This term we need to use.
And is that a consensus?
Yes. It is published in 2018, but after this paper, the most of the researchers accepted this concept. So when we want to study about the tumor body, then that cluster should be consist of less than 4 cells.
Hmm.
And this is also disease specific survivor. And about the lung cancer, also tumor budding as a marker for poor prognosis.
Hmm.
And regardless of the histology type of lung cancer, even in lung squamous cell cancer, even in adenocarcinoma, the tumor budding shows a poor outcome. And these are the survivor outcomes in lung cancer. Overall survivor, disease specific survivor, and progression free survival.
Hmm. Low grade, high grade. So BD 1, 2, 3.
Mhm.
So there's a grade and high grade is BD3. Okay.
Yeah, this is based on the article which was written by Consensus team,
Hmm.
as I showed you before.
Colorectal, right?
Yes, but this paper accepted that category, BD 1, 2, 3.
Same system applied to lung.
Yes.
Can you go back?
Back where here?
So lung and squamous, there was no difference in pattern of, well, I guess is budding similar? Was there I guess, future. Can you go back one more?
Mhm.
Hydro grade, this is all combined, I guess combined, okay.
Mhm. Yeah.
Yeah, I guess, colon is adeno, so lung adeno might behave same. I don't know
Mhm.
in its squamous level if there's any, any difference in behavior or anything, but it looks like the pattern looks similar.
Yes, I thought first, but they said the tumor burden is a higher tumor stage in mediastinal lymph node metastasis.
Hmm.
but not the presence of mediastinal lymph node metastasis. That is not.
Not associated with presence of, yeah.
Yes, yes. So I wanted to distinguish between stars and tumor body.
Hmm,
And the different point is the stars only present in airspace. The
airspace,
tumor, yes, tumor budding is present in the stroma. So
Hmm.
that's the point. And that could be interesting study when we compare the stars, presence of stars, presence of grade of tumor budding, and absence stars, and the grade of tumor budding. Maybe we can divide it in lung cancer. Okay, so this is what I told you. And in breast cancer, based on the subtypes, tumor budding all have a relationship in the each subtype ER peer group HER2 Ki67. And also, this 7 means the number of the tumor buds. So this is just one article, but according to the article, they said the 7 could be the standard point to dividing the survivor.
Hmm. Wait.
Yeah.
So if you use 7 and then you can create 4 different graphs like this. Hmm.
Mhm.
So with budding or less budding, more budding. Okay. And do you know what stage this is?
Stage, I don't know.
Oh, it's okay.
And the tumor budding is also could be a prognostic factor in patients who receive the neoadjuvant chemotherapy.
Mm-hmm.
Oh, here, tumor budding is not different based on subtypes. They all have a relationship, but not difference between each subtype.
Okay.
And in breast cancer, this is just one article, but they say tumor budding is not related to OS,
Hmm.
but related to progression.
Okay.
Mhm. And so this is all I have today. Tumor budding, maybe we can see the tumor budding in Lunis study. And I think if the pathologist can distinguish and they know this concept of tumor budding, then HNS slide will be enough to
Mhm.
see this one.
Okay. Well, thank you. So I think I have a few comments and suggestions. First of all, very nice review. This is a nice, good example for you all of you guys to do. You know, how do you do research on one topic and find what's relevant, what's not relevant. So so everything you guys, Dr. Jian, your previous prior all journal clubs, everything you presented, right? So talk to Liam and Eugene, the managers know where the Google Drive is, so we
Mhm.
share all our previous journal clubs in one place.
Okay.
So make sure you store that in there.
Okay.
And Eugene, there's a, we have our lab account, right?
Yes.
You know?
Yes.
Yeah, so yeah, tell her how to store it and also share that account's ID password with our all like the current lab members. So that they can go in and see what has been presented before and they can learn from the prior PowerPoints and any reference article or any published paper, anything, your posters. Actually, I recommend that we start. We've been doing it before, but we really just haven't been doing it well. But make sure we store everything in one place. Everything that comes out from our lab, journal club, PowerPoints, our papers that are published, PowerPoints that are presented at our, or the posters that were presented at our meetings. Let's continue to
Together.
put them in one space, Google Drive. So Liam and Eugene, I ask you to follow that up and start collecting them so that we, and once you start collecting it, send me the ID password for the, because I don't think I have it.
With your account.
Or, yeah, the account.
Okay. No problem.
Okay. All right, let's go back to the topic. So the things that are important here is, obviously Lunit will say yes or no,
Mhm,
but they need to grade it 1, 2, 3, right? As the
mhm.
consensus. Let's make sure they do that. And then I don't know if Lunit will look at the lymphovascular invasion, other things, but I don't think they will. But anyway, what we actually ask them is 2 things. From the breast H&E slide that they will be receiving,
Mhm.
give us the TLS and the tumor budding score. From TCGA data, let's start from lung, because that's where we have published before. So in the lung, let's look at the tumor budding score, TLS, and link it with everything else that they looked at before, including the Lunit scope score and immune subtype and so forth. The same thing can be done, TLS budding score and Lunit scope score, they will do it. And clinical outcome. So that's, I think, what we are interested. For lung only, because it's airspace, we want to look at STAS. And what you said is exactly right. STAS doesn't mean there's a lymphatic spread.
Mhm.
So budding is more like, yes, the ECAMP, EPCAMP, and ECAD-herin is, so it's more like EMT, it's more like, what do you call it? Metastasis potential.
Mhm. Yeah.
Yeah,
Definitely.
more than anything, budding is
Mhm.
try to go out, and we're just capturing that process. STAS is a little different. It might be just different biology. So I agree. Now, whether seeing more budding means any change in immune landscape, we don't know, right? So I think but the TIL and budding may be 2 different indications, 2 independent phenomena that's happening. And that 2x2 TIL high low and budding high low, that kind of describes what we think will happen, but I think showing that in breast cancer is I think is important. Neoadjuvant setting is important, and also the pathways. If we can do this TCGA, that's important. And then once we see something interesting in neoadjuvant cohort, then we can go to TCGA breast.
Mhm. Mhm.
I don't know if anyone published that. If none, Because what's powerful is TCGA breast, the Lunit scope has already been done. So you can just do the tumor budding and TLS and all that, and that could be a nice, we've done American Journal of Pathology paper
Mhm.
with lung. The same can be done for breast.
Okay.
So that's a nice potential paper that can pan out from this project. Because no one has done it, because you can do the GSEA and look at the pathway analysis, link that. I'm thinking someone will already probably have done it, but if not, this is still a good learning opportunity.
Mhm.
So that, and really the implication is, therapeutic implication. So would tumor budding cause more resistance or a bad outcome? Do you need to intensify therapy, or what does it tell you? In colorectal, if you had tumor budding, giving just 5-FU, let's give not just FOLFOX, but can we give FOLFIRINOX for that, even for adjuvant therapy? Or rather than 6 months, if high tumor budding, should we give 12 months of adjuvant therapy? So again, the role for biomarkers should be, how can we optimize our therapy? Not just say, well, this is bad sign. Well, if you end there, what's the purpose of developing a marker? It has to change management. So same thing as a clinician, I think Dr. Jian will do that to her residents as well. Someone orders, like, if you're not going to change management, why are you ordering this? We do it all the time. So why did you order it? Give me rationale. And then you're like, oh, I want to know. Like, that's not good enough. Like, you wanting, your curiosity does not, justify the cost of the test. So you always have to have, when we do research, same thing. If you do research because you're curious to know what's happening in TCGA, don't do it. Please don't. You're using energy and time and resource of, precious people and resource. So if we have a clear mind, tumor budding, after reviewing the data, well, it correlates pretty well. And if you can predict lymph node, then it should be incorporated, and it's, and it's and what is the relationship with the immune microenvironment? So I think what Dr. Jian showed us is pretty compelling enough that yes, we should definitely look at its impact. And therapeutically, we're exploring it in neoadjuvant first. But in terms of lung cancer, it's not being explored other than prognostic yet, right? So what is the predictive role in immunotherapy? We don't know, right? So one other thing we can do is, let's say we have a Regeneron project. Regeneron is making semiplimab, which is PD-L1 inhibitor. And Regeneron just approved our proposal that they will send their phase 3 clinical trial H&E slide images to Lunit. So Lunit can look at tumor budding, TLS, everything,
Mhm.
see if it has any predictive role. And what is its relationship with PD-L1, PMB, Lunit scope? Is it all orthogonal, which is independent of each other? Then it makes case for developing an algorithm, prediction score. If it's related, we got to figure out how is it related. Can't figure out then we have AI build up on algorithm. So this is how, our working model. So yeah, those are my thoughts. But stats is pretty unique. We should still
Mhm.
pursue that as well. I know you presented on the stats before. Was it you or who presented on the stats?
이상.
지상? Oh, 지상.
Mhm.
Yeah, I know you guys looked at it both, but. Oh yeah, same thing. Liam, get the slides from Chisang and store it in our Google Drive as well. Yeah, stats is very unique. Yeah, and then what is the pathway that has to be turned on to make that happen? It may be airway dependent and you don't know. So I'll stop here and Jian, what was the paper were you?
Oh, yeah, I thought that was the TCGA data, but it was not. It was just came from the Samsung University, Samsung Medical.
Oh, it was not TCGA? Oh,
Oh, not TCGA.
oh,
So no one published about the Luniscope and with the TCGA data.
oh, okay. Yeah, it's thousands patients and that's where we find major
Mhm.
discoveries. So, good. Once, I think once Lunit finishes the lung, and then we can
Mhm.
talk about the breast. And we don't want to, burden them too much. So
Yeah.
keep it as the potential future projects. Okay. Anything else, Jian?
That's all I have today.
Okay, very good. Okay, Uni, can you present?
Can you see my screen?
Yeah.
So I'll be presenting about this paper. I think I understood the basic concept. I don't know how much I understood the full paper, but I'll try to do my best. So this paper was published by this group of Johns Hopkins University School of Medicine team, detecting liver cancer using cell-free DNA fragmentomes.
What was the journal again?
Journal, that's I need to find that was Cancer Discovery.
Cancer discovery.
AACR.
Cancer discovery paper. Okay.
So intro, liver cancer, one of the leading cause of cancer-related mortality. And it's actually one of the few cancers that its incidence and mortality is going up for the past 20 years. So that's interesting. And even though it has a clear risk groups, including hepatitis B infection, cirrhosis with multiple different causes, it still has a poor adherence to the screening and also poor sensitivity and specificity to the current screening. So Delphi technology, it's basically measuring how the DNA folds within the nucleus by assessing the size and amount of fragmentome. And on a healthy cell, the way they package that within the cell, it's very organized pattern, but in a cancer cell, it's catastrophic, and also some of the items like genes thrown randomly into the structure. That way it generates different patterns into the fragmentomes. And this technique analyzed the pattern of a fragmentation across the cell to develop a scoring system, and eventually use the score to early detect the cancer in the future. So in the study, there was clinical cohort, validation cohort, and clinical cohort was from the US. Validation was in Hong Kong, which is unique because they also studied in a different patient population. And these are the patient demographics and clinical information comparing between non-cancer individuals and cancer patients. So fragmentation profiles were consistent among individuals without cancer. As you can see, the first three things, like for 3 lines, patterns are similar, but the patients with HCC, they have very highly variable patterns. And profiles of patients with cirrhosis, viral hepatitis were closer to non-cancer individuals without liver disease than they were to those from patients with HCC. And to this this graph, this figure of B, its purpose is to examine the origin of the cell-free DNA fragmentation pattern, and they analyze the genome-wide fragmentome profiles. So you can see the 4th and 5th one, individuals without cancer cell-free DNA and lymphoblastoid cell, they look pretty similar. And the very top one is the hepatocellular cancer tissue reference. And the way they interpreted this is that this so this is the second part, extracted hepatitis cell hepatocellular cancer patients cell-free DNA component. This was extracted from the patients who had higher ctDNA. So way they saw it is that in the first one is closer to the combination of 2 and 4, more than hepatocellular cancer patient cell-free DNA, meaning that this pattern is not just from the cancer, but it contains the information of the both plasma and the cancer cell. And as a chromatin organization reflects underlying cellular transcriptional programs, they examined whether altered DNA binding of transcription factors in liver cancer can affect cell-free DNA fragmentation characteristics. And in this figure, they compared these transcription factors in patients with or without hepatocellular carcinoma to identify those transcription factors with the largest and smallest differences in genome-wide binding site, and differences in this cell-free DNA transcription factor binding coverage between hepatocellular carcinoma and patients, like individuals without cancer, were related to liver and other cancer. And on the figure A, you can see compared to figure B, that there were more differences in each of the transcription factor and activating genes. And those red transcription factor activating genes are related to generating more of a tumor genesis. And they also wanted to see if if this genomic change is actually from the cancer specific location or the in a larger scale genomic alteration. So in here, genome-wide fragmentation profile, they showed chromatin and transcription factor in the patients with liver cancer. So if you see the number 178 in a HCC patient, it's correlated with the TCGA profile in a liver cancer, which is not that significantly sticking out for the patients with cirrhosis and viral hepatitis. So with this Delphi model, they created a score which can predict detection of liver cancer. And there was no association of Delphi score with age, no difference between different sex. Interestingly, Asians and African Americans, higher incidence of liver cancer with a higher score, and small differences in fragmentation scores among high-risk individuals without cancer across these or other racial or ethnic groups. And among individuals with cirrhosis, there's a correlation between the degree of disease measured by Child-Pugh score and increased body BMI, risk factor of non-alcoholic fatty liver disease, liver cancer, not associated with change in Delphi score. However, lower BMI was associated with higher Delphi score. So the main focus of this study, it's to see the utility of this tool to detect the cancer earlier. So they created this ROC curve and measured the AUC value. And on the figure C, you can see from the different staging of the liver cancer, first two is the early stage and the last two is the advanced stage. And as you can see, more the advanced stage, its detection rate is actually very good, like more than 98%. And overall specificity and specificity are all above the AUC curve is above 0.0 0.9. And within this Delphi model, tumor size and lesion number positively correlated with Delphi score. Among patients with liver cancer at the earlier stage, like with considering all these confounding factors, had a similar Delphi score, suggesting that fragmentation profiles was a result of ongoing tumor-related cell-free DNA rather than other disease processes. And among individuals that had a high low AFP value and who have been undetected by this approach, Delphi also detected 30 of 36. And basically saying the cancer that could have not been detected by a AFP measurement is more likely to be detected by a Delphi approach, regardless of the stage. And they did this external validation model in East Asian population in Hong Kong. Overall had a higher AUC of 0.97 with a high risk. And they also this Monte Carlo simulation, making this 10,000 100,000 simulated patient population, and they say ultrasound with the AFP would have detected an average of around 2,000 individuals with liver cancer. Delphi would detect on average of more closer to 3,000 additional liver cancer cases, for 2.4-fold increase compared to ultrasound with AFP alone. Delphi approach not only substantially improved detection of the liver cancer, but was also expected to decrease the false negative rate, and negative predictive value is expected to be going up. So one of the things I didn't mention earlier is that because this test requires a low coverage whole genome sequencing, they require a smaller amount of specimen, and which makes it cost effective. And compared to the conventional ultrasound combining with AFP screening, this is more accessible, cost effective, and with sufficient numbers of patients, cell-free DNA transcriptional profiles could further improve machine learning algorithm to detect hepatocellular carcinoma, but furthermore other cancers as well. And this part, and there's a limitation in a small size of a patient population in the study, and of course, because it's a lab value, different labs use different diagnostic approach, and larger validation studies will be needed before this approach can be useful in the clinic.
Thank you. Yeah, good job. It's a great paper. I think you tried your best to summarize it and get the point across. So yeah, so I appreciate the time you spent. I wasn't able to understand the last two figures. Can you go back? Because
Last two, this one,
no,
this one.
no, go back. Let's go back. Yeah. Go back one more. Yeah,
This,
yeah, let's go with this one. So here, I'll give you a tip. When you explain figure,
mm-hmm,
go title of the figure. What are we try to prove?
mm-hmm,
What is x-axis? What is y-axis?
mm-hmm,
So you try to make people understand how to interpret graph first.
right,
And then what is B? What are they comparing it? What is the purpose of this? And the
mm-hmm,
pattern you actually see from these, what patterns are similar, what is not similar,
mm-hmm.
and how did, what do we try to learn from the graph C? So can you re-explain? I couldn't understand.
So this figure is to examine the origin of the cell-free DNA fragmentation pattern. And so I actually don't understand much about this high throughput sequencing chromosome conformation capture called Hi-C. And the x-axis is supposed to be the AB compartment, which is the Hi-C. And the y-axis is the fragmentation profile. And I think they are trying to show us the resemblance between, first resemblance between individual without cancer and lymphoblastoid cell. That's this fragmentation profile is generally similar to the fragmentation profile in lymphoblastoid cell. And secondly, the second line, it says extracted HCC patients cell-free DNA component, and they are the group of patients had with a higher ctDNA compared to other HCC patients. And I think they're trying to say that the this extracted HCC patients component has a little bit of a both of a HCC tissue reference profile and individuals without cancer cell-free DNA.
So let me ask you this.
That
What are they trying to prove? Through this analysis, what is their, take-home message?
with this figure, they're trying to say that this sample is from like represents both plasma and the cancer cell.
I don't understand your statement. Can you show me Show me what it says in the bottom. Show me the.
Yeah, I let me see.
So chromatin conformation capture means that the DNAs are wrapped around the chromatin. And
Mhm,
when they're active, they're open.
mhm.
When they're
Right,
not open. So it's
yeah.
A and you look at their ratio, you look at their pattern, what's close.
Oh,
Um, So again, if you don't quite understand the technology, keep reading.
mhm,
Google, okay, go to, understand the technology. If you don't understand the graph, keep reading, find similar paper, make yourself understand first. Then only then you can teach others what it is.
mhm.
Okay, that's probably the lesson you learned from this.
Yep.
C, so can you show me the graph C?
See.
This is odds concordant with HCC tissue reference, AB compartment. So if the odds are high, then higher concordance. The concordance is higher with extracted HCC patients cfDNA component. So what is the difference between extracted and just HCC patient? Extracted means it came from tissue?
Um,
What does that mean?
in the paper, it didn't specify. They didn't use the word extracted, so I just assumed that it's a analysis of cell-free DNA profiles from 10 HCC patients with high ctDNA levels.
Also selected, extracted is selected 10 patients, is that what it means?
That's how I understood.
And just the HCC is non-selected, just everybody?
Yeah.
Okay. So tissue reference is tissue. And then you have selected and you have HCC. And then individuals without cancer. So now I can see from top to bottom, there's a gradation, like, gradual change, but whether it's extracted or just HCC cfDNA, the patterns are two patterns, top and bottom patterns are seen on both. And so,
Mhm.
Okay, I think I got the point now, but it's. I think for papers like this, because people
Mhm.
know the technology. When you do future journal clubs in your residency fellowship, I suggest that you understand it perfectly first. And then if you think people don't know the technology, you have to explain what the technology, what is HiSeq,
Mhm.
what is fragment profile, what is
Right.
the compartment. Like people will raise your hand like, oh, what is AB? I don't understand.
Mhm.
Then you're like, oh, I don't know either. That will make you look bad. Okay.
Yeah.
When you do journal club, make sure you understand every terminology, every technology.
Mhm.
That's how you present. And the main message, if you don't understand, and then you can be bold as to say, if you don't understand the technology, the main message is that from ctDNA, cfDNA, we're not even looking at CT, cfDNA, you
Mhm.
get both signature at the same time. It will show up, and
Right.
it will be the computer algorithm that will extract the HCC related chain
Mhm.
and tell us whether there is cancer or not. So
Right.
yeah, if you can get the message across, I think that's important.
Mhm.
Okay, next graph.
Next graph.
Explain that to us one more time, because I think I get it, but I don't understand the whole how they came up with figure C and D.
This one was also very confusing. The so the figure A and B, I think all these column on the top with different names that represents different activating factors, and on top, like A, there's difference between the red line and the gray line, which I think is the difference between the cancer patient and non-cancer patients. And I think that makes difference in tumor generation. And those 9 factors in the A, so they are related to generating tumors compared to those in Bs.
So that's what you think. That's how you explain it, which I would.
Mhm.
It is not related to generating tumor. Generation, creation,
Mhm.
these mean causality. You do
Right.
know whether these gene
Right.
factors have
It's
any.
related. Yeah.
Yes, so you have to watch your language when you explain.
Mhm.
I'm trying to teach you how to be a good presenter.
Right. Yeah.
So same thing here. So is it so? So here's the thing. So is it just the pattern of which part of DNA is open or not open? Or
Mhm.
we also delve into the biology, the essence of the biology, what genes, activating factors are related here or not. So that's why we did this analysis, and we found some activating factors that are different between cancer and non-cancer.
Mhm.
That is the. Here's the relative coverage. So I think we need to understand how the coverage was. Is it the openness, or whether this part was closed or open? I don't know what relative coverage means. So that's a but I'm just guessing. I have to is it same as this is not RNA sequencing. There's no RNA here. This is all DNA. So how did
Mhm.
they, I think it's the openness of that. But it's your job to understand what that is and see how did they come up. So I guess that color red is liver, lung, and other cancers are here.
Mhm.
And what's on the left side and right side, and how, what is that mean? Like, I don't understand. So first of all, if you can explain it well, show us the figure legend. I'll understand as best as I can and try to
Okay.
explain it back to you.
Let me actually pull up that. Um,
So same thing, another lesson is, if you don't understand, that's why I'm here. You come to me and ask, "Oh, I don't understand this figure, Dr. Chi, how do we, I read it, I
mhm.
all different references, I still can't understand it." Then you
Mhm.
say, or you ask someone.
Figure.
Go to figure legend. Where's the figure?
Maybe it's on page 22.
Figure here. This and this. So it was figure 2C.
Okay. Where is it?
Fragmentation profiles in HCC patients.
Coverage at and around the transcription factor binding site for 9 transcription factors for which the relative coverage at the binding site that had the highest separation. So the coverage is the DNA sequencing coverage. It will be
Mhm.
because when it's open.
Mhm.
Mean the coverage largely overlapping, reflecting their status as transcription binding sites with poor discrimination. Gene set enrichment analysis of TF analyzed in both HCC and lung show that TF are separately enriched in numerous pathways related to liver and lung respectively, including adult liver carcinoma and adenocarcinoma. So it was done based on the gene enrichment, gene set enrichment analysis. But this one I didn't know. So let's go back to the graph. Can you just just that C alone?
Oh.
So liver neoplasm goes to liver. So I still don't understand how liver and lung is on the top on the right side. Dr. Jian, can you help me? I try to understand how they made this order. It's gene expression. They said gene set enrichment analysis. The point is lung and liver are different. But how they made this graph?
Can I see the lesson again?
Maybe is it in anything in the text? Yeah,
Text.
yeah, go to figure 2C where in the text it describes it.
Go down.
Ah, this-
Maybe in research section. Let's go up.
Here.
Go to figure 2. Okay. There is an explanation about figure B. Here, the coverage.
Is there anything in the text about figure 2?
On page 5, there's some contents about figures. On page 5.
Okay. For each we calculated aggregate cfDNA coverage all across the binding site. So that was figure 2AB. Gene set enrichment analysis using this GeneNet database of gene disease association. So this is what you need to do. You need to read what this is and how to interpret gene disease association. There's a set rule to produce that kind of graph. Revealed so study what that is, how to do this, how to interpret.
Mhm.
Reveal that let me finish reading. Revealed that difference in cfDNA TF binding coverage between HCC and individuals without cancer were predicted to be related to liver and other cancers. Additionally, that was table 2. So the whole point is there are specific transcription factor activating sites that are liver cancer unique, specific. I mean, that's the whole point.
Yeah.
But I think we have to understand this GeneNet to understand that.
Yeah.
I don't get it. So read about it and let me know anytime today, okay?
Yep.
Okay, and
Do you wanna
back to
go
your
back?
and the next graph.
this.
So these are the figure 3, the relevant. The figure 3, these genes are log odds ratio. I'm trying to understand. What the ratio is high, then your odds ratio. It's like odds ratio of being liver cancer. Is that? I'm trying to figure out what that. Principal fragmentation compounds. So what is this log ratio of having liver cancer?
Cancer biology.
Same thing. Let's go to the figure legend. It will say. Yeah, because I've not seen graphs like that, so I need to understand what that is. What's the figure number 3?
Figure 3, yeah.
Map. Copy number C. Was it the C?
It was C, yep.
Heat map depicting the contribution of individual genomic region to the final trained Delphi model. Okay. The fragmentation features were summarized as 3 principal components in the model, while aneuploidy was summarized as arm level z-scores.
Dr. Chan, sorry to interrupt.
Huh?
Your schedule says you have a meeting with Dr. Kurzrock right now.
Oh, really?
Yeah. It's 11:15 CST.
Oh, I didn't know they put her on my schedule. All right, I will stop the lab meeting here. I gotta get on to the meeting. Thank you for letting me know. We'll resume the lab meeting later on.
Okay.
Thank you.
Thank you everyone for a wonderful.
Thank you.
Thank you.